You will probably not register everything, but you will get an idea, and you can always go back to either this those slides or to the books. The idea is to get an overall impression. It is a lecture, therefore it's not a seminar, so it's not going to be very interactive. But if there is a point that is not clear, please ask. Venous thromboembolism in obstetrics. Next slide. Next slide. It's not very common, 1 or 2 per thousand, 1 or 2 per thousand. But we like to address it because it is very serious. When it happens, it is very serious. And pregnant women are more predisposed to venous thromboembolism, 5-fold increase compared to women that are not pregnant. And postnatally, 20 times commoner than in their non-pregnant counterparts. Antenatally is deep venous thrombosis. Postnatally is the deadlier one, pulmonary embolism, 20 times higher than non-pregnant women. Next slide. Why are pregnant women more predisposed to deep vein thrombosis and pulmonary embolism? For those 3 reasons: stasis, hypercoagulability, and endothelial injury. Stasis because the left iliac vein is compressed by the right iliac artery, is commoner on the left side, because we're talking about the left iliac vein. And we have to remember that venous thrombosis is not only in the legs, but it could happen in the pelvis, in the iliofemoral veins. Hypercoagulability, it's a defensive mechanism. In the normal woman, you need to have efficient coagulation system to cover for blood loss at delivery. You know, the placental bed is quite large. It's about 25 centimeters in diameter, and they need the uterine muscle needs to contract. Well, the coagulation system needs to kick into action, so the woman does not lose all her blood. Can you imagine a defect that's 25 centimeters in diameter? Is huge. So some clotting factors are increased, or some anti-clotting proteins, C and S, are decreased, or there is resistance to their action, or fibrinolytic inhibitors are increased through tissue plasminogen activator and plasminogen activating inhibitors. And acquired antithrombin deficiency. So all those will make the woman more likely to clot. Next slide. Yes, the anatomy one, please, Rawan. Here you can see the left iliac, common iliac, is compressed by the vein, is compressed by the right common iliac artery. Interesting piece of anatomy. Next. Now, risk factors for VTE, the risk factors for VTE. Some are pre-existing, such as thrombophilia, chronic medical problems, age over 35, body mass index over 30, parity more than 3 or more, smoking, varicose veins, paraplegia. These are all pre-existing. You have them, you can do nothing about them. They're there. Next. Obstetric risk factors, these are only while the woman is pregnant. Multiple pregnancy, preeclampsia, cesarean section, prolonged labor, forceps, stillbirth, preterm birth, and postpartum hemorrhage. And transient ones, such as appendectomy, hyperemesis, ovarian hyperstimulation syndrome, long hospital stay, infection, and long airline travel, or actually it doesn't have to be an airline, it could be in a car going to العقبة أكثر من 4 ساعات, فده will predispose you to DVT. Next slide. These risk factors are important, and as you saw, there is more than 20 of them, more than 20 risk factors. So if the woman has 4 risk factors or more, you anticoagulate them prophylactically straight away, as soon as you diagnose pregnancy in the first trimester. Now, if you have 3 risk factors, you start prophylaxis, not therapeutic, but prophylactic anticoagulation from week 28 and all through the puerperium, 42 days after delivery. After delivery, if they have 2 risk factors or more, you anticoagulate them for 10 days. Any questions so far or comments? Yes, no questions. All right, so risk factors, you saw the risk factors. Now, each risk factor has a score. Each risk factor has a score. As you can see, some score as high as 4, like previous VTE, 4 marks. Previous VTE provoked by surgery, 3. Known high-risk thrombophilia, 3. Medical, chronic medical problems, heart problems, kidney problems, liver problems, bowel problems, sickle cell disease, 3 marks. For this one risk factor, they get 3 marks. The others, you can see, they mainly 1 mark, except for obesity. If they are morbidly obese, more than 35 BMI, then they 2 score points. Hyperemesis scores high, 3. And ovarian hyperstimulation for infertility treatment, 4. Why am I telling you this? Because each risk factor is given a score, and you add the scores up, and if they 4 or more, then you start straight away. 3, you start at 28 weeks, and you carry on for 6 weeks after delivery. And if they have no risk factors, but after giving birth, they have 2 risk factors in the puerperium, you prophylactically anticoagulate them for 10 days. After delivery, we become more aggressive after delivery because it is commoner and more serious after delivery. Next slide. Yes. Prophylaxis, you stop it if there is bleeding, of course. Next. No regional, basically, no regional anesthesia, that's spinal or epidural, unless you leave a gap of 12 hours from the last dose. Anesthetist will not agree to insert an epidural catheter or spinal anesthetic if the woman has had low molecular weight heparin because of the risk of hematoma, spinal cord hematomas. Next slide, please. If you plan a cesarean section, then you stop the day before. Next slide. Previous VTE, you anticoagulate after delivery, antenatally and after delivery. Low molecular weight heparin before delivery, low molecular weight heparin after delivery, or warfarin if they don't want to have injections. But we don't give, we'll tell you in a minute about it, no warfarin antenatally. Now, if you read this slide, I'm just going to just focus on it for a minute, please. So, low molecular weight heparin is the drug of choice. No need for monitoring of anti-factor 10 levels. You don't need to monitor the platelet count because, you know, with the conventional heparin, there is a problem with thrombocytopenia and osteoporosis. You gotta be careful if the woman has renal dysfunction. Next slide. Warfarin, no warfarin. Antenatally, you do not give warfarin unless a cardiac surgeon tells you that this woman has an artificial valve and I want to have to carry on warfarin. Then you say that's fine, but we have to tell the mother that there is a risk of congenital anomaly and that we have to take this risk. So there is a 5% chance of embryopathy, abnormal face, nasal bridge, heart defects, brain defects, bone defects, miscarriage, stillbirth, neuro problems, and hemorrhage, of course. But it is safe in breastfeeding. So simply no warfarin unless a cardiac surgeon tells you that he wants her to be on it and to take the risk. Next. Next slide. Don't worry about the doses. These are low molecular weight heparin. Contraindications. You don't give low molecular heparin if there is allergy, bleeding disorder, bleeding, thrombocytopenia, less than 75, brain hemorrhage, renal or liver disease, or hypertension because of the risk of intracranial hemorrhage. Next slide. Okay, so up till now, we have spoken about prophylaxis. Now we're going to talk about therapy. A woman, a pregnant woman, has DVT. Not risk of DVT, she has DVT. As you can see in the pictures. Next slide. How do you know that she has DVT? You suspect it clinically. Swollen, edematous, tender, painful leg, or pain in the pelvis. Pulmonary embolism, dyspnea, hemoptysis, even collapse. Maybe low-grade pyrexia and leukocytosis, but they are not very diagnostic. Okay, you suspect it clinically, what do you do? If you suspect it clinically, listen to me very carefully. If you suspect it clinically, you start treatment. You start treatment. Then you investigate. I suspect DVT here. Start treatment straight away. Straight away. And then investigate. How do we investigate? Next slide. Compression duplex ultrasound. Ultrasound. Why is it duplex? Called duplex? Because you look at a picture and you look at flow at the same time. Picture and flow. D-dimers are not very useful. We said you start treatment. You do CBC to make sure there is no thrombocytopenia. Coagulation screen, there is no coagulation defect. Liver and kidney function, because you have to modify the dose if they have renal or liver function problems. And if they have severe liver function problems, perhaps the low molecular weight heparin will not work. And with kidney function problems, you have to decrease the dose or look for another preparation other than low molecular weight heparin. You don't need to screen for thrombophilia because you're going to treat anyway. You're going to treat anyway. So I'm not going to look whether she has protein C as antithrombin or factor V Leiden or MTHFR or whatever. Because I'm going to treat anyway. Next one. Next slide. Next slide. If they have leg DVT, you can put the elastic stockings or they can mobilize. Now, there is something very interesting here. If you're very worried that the patient may throw a pulmonary embolus, then you may consult interventional radiologists to insert a, a temporary inferior vena cava filter. It's like an umbrella you put in the IVC so the clots will not go up. You carry on for if they have the VTE of any sort, they should be treated for a minimum of 3 months. Say if a woman gives birth, develops a VTE, it's not only the porphyrium 42 days, but 3 months. Here we're not talking about prophylaxis, here we're talking about therapy. Next. If you do cesarean section, it's not a bad idea to put a drain to make sure you monitor any blood loss. So you don't monitor the dose unless the woman is under 30 kilograms, more than 90 kilograms, or on unfractionated heparin. In some cases, we use unfractionated heparin. It has a shorter half-life and is easier to reverse with protamine sulfate. When you send them home, you teach them how to self-inject. Same like for diabetes. Next slide. Now, if a woman tells you that she is short of breath, chest pain, hemoptysis, and you suspect pulmonary embolism, if you suspect pulmonary embolism, you start treatment straight away. Straight away, therapeutic doses. And in the interim, meanwhile, you do chest X-ray and ECG, duplex ultrasound, CT pulmonary angiogram, or VQ ventilation perfusion scan. You do all those to confirm the diagnosis. If the diagnosis is confirmed, you carry on with the treatment. If the diagnosis is not confirmed, but you are highly suspicious clinically, you carry on with the treatment. If you're not, hello? If you're not highly suspicious and the tests are negative, then you may consider stopping the treatment. Now, chest X-ray is helpful. ECG will show you the S1Q3T3 pattern. That is S wave in lead 1, Q wave in lead 3, and inverted T wave in lead 3. Right bundle branch block in V1, M wave in V1, and broad S wave in V6. It may help. It may help if it is positive, then that is helpful. If it's negative, then it's not very helpful because the false negative could be high. Okay, so treatment and investigation. Next slide. This is ventilation perfusion scan. You see, it's not terribly diagnostic. You see on the left, the ventilation is okay, but on the right, the perfusion, there is some defects at the base and on the left middle. Next slide. But here, the CTPA pulmonary angiogram, it's very, very clear that there is a thrombus and the bifurcation. Rowan, can you point the mouse on the thrombus? There it is. There it is. No, down, down. Yeah, yeah. Inverted V, the black one, the black one. Yes, that's the one. That's the one. That's the thrombus on the bifurcation. Next slide. And here you can see the arrows. Rowan, can you point to them yourself, please? You can see a blood vessel with clots in it. That's more conclusive. Next slide. Okay, we finished. Low molecular weight heparin is the drug. 4 risk factors antenatally straight away. 3 risk factors, 28 puerperium. 2 risk factors in the puerperium, 10 days. Next slide. Okay, I think we've done very well. Can we have questions or comments? While you're thinking, I think what we will do, just in case we have only 40 minutes and we've done half an hour now, what we can do is have a discussion or questions, and then we re-enter